All right, thanks, Amy. Good afternoon. Thank you to all who are joining us today, those who are returning, those who may be here for the first time. We're happy to be able to offer another session of our Workforce Collaborative Training Series to all of our providers in our community. Today, we're very excited to have Sarah Bonk, LMSW Commissioner, Erie County Department of Mental Health, Deanna Schaumloeffel, Crisis Response Diversion Coordinator with Crisis Services, and LaTonya Diggs, LMSW Director of Clinical Quality and Transformation with Value Network, with us to share the introduction to the mental health crisis triage tool. A few quick reminders. At the end of this session, we'll be asking everyone to complete a very brief evaluation. Please take a moment to fill this out so we can continue to improve our training series. Our next session will be Tuesday, August 26th with Elizabeth Leonard, Senior Therapist at Horizon Health Services on grief and loss. Be on the lookout for registration information, which will be emailed out soon, and we did just post this to our website. We are continuing to fill our calendar for 2025. If you are interested in doing a 1-hour presentation or you're interested in a particular topic, please indicate that on your evaluation, or you can email Amy at amy.rockwood@erie.gov. The recording and slides from today's presentation will be posted to our website within the next few days or by early next week. The presentations and recordings from our past offerings are posted to our website as well, so we'd encourage everyone to check those out. The training is being recorded today and everyone is muted. Questions will be taken at the end. If you need anything, I'll be monitoring the chat during the presentation. Thank you again for everyone joining us today. I'd like to now turn it over to Sarah to talk about an introduction to the mental health crisis triage tool.
Thank you very much, Kathleen. I appreciate it. And good afternoon, everybody. I am very excited to be here to kick off this particular training. As from my perspective, this is really an opportunity for us as a community to align ourselves and be on the same page, no matter where you're working or which population of behavioral health you're working with, to ensure that we're all walking in the same path when it comes to understanding crisis and what those options may be for various individuals in our community. You're going to hear from two of our local experts, both LaTonya and Deanna, and they are going to walk you through how to use this tool. But this is something we also will be looking at, sort of the adaptation, or really making sure that we institutionalize this training tool to assure not only that now, but in 5 years from now, there is still that consistency amongst both us at the leadership level, but as well for individual clinicians who may be interacting with folks on what crisis is, what an emergency may look like for an individual, and what the best resource is for that particular experience the individual is going through. So I'm going to turn it over. I will turn my camera off, just not to distract anybody, but I will be here and remain very present. I will turn my camera back on during the question session, but I want to make sure that I am not distracting. But I'm going to turn it over, and LaTonya and Deanna are going to walk us through this incredible tool. But LaTonya, I'm going to kick it to you.
Thank you so much, Sarah, and welcome to all who have decided to come and join us today to talk about this tool. Just wanted to go over the agenda really quick. Deanna is going to really walk us through the crisis framework, how we're applying this to real life situations, and really understanding some of the local resources that are available outside of the just CPEP as an option to have people get serviced. But then also, again, really looking at ways to apply this tool to real life situations. So I'm going to hand that over now. We will have time for questions and answers as well, but we're going to hand it over to Deanna so she can walk us through.
Awesome. So hi, I'm Deanna, and I am going to go over the mental health crisis response triage tool. As LaTonya said, we will do questions at the end, but if you don't want to lose your thought process or your question, feel free to put it in the chat and we'll go back to it at the end. So this is a collaborative effort between Value Network and Erie County, and we did also include this disclaimer. I promise I'll only read it once, but the information provided in this training is not intended to be utilized as a clinical screener, a clinical decision tree, or a diagnostic tool. Rather, this training intends to offer general guidance to be used in conjunction with the clinical supports and tools available to you to assist with connecting individuals in care with referrals to the appropriate level of care. You are advised to consult your supervisory or other clinical resources when making any clinical determination. So just to kick us off, the training objectives of this is to just introduce basic concepts behind the tool, explain the application of the tool, and offer guidance on how you can provide the most appropriate level of care during a crisis. Again, the purpose of the tool, it's providing health professionals, clinicians, paraprofessionals with the adequate tools to identify and connect individuals who are in crisis with the appropriate level of care. We did break it out into the crisis response framework from SAMHSA, someone to talk to, someone to respond, and somewhere to go, and we will break those down further a little bit later. So first, we had the discussion of what is a mental health crisis. A mental health crisis is an intense state of confusion and anxiety where usual coping mechanisms no longer work, leaving individuals feeling vulnerable, anxious, fearful, and even helpless. How a crisis presents, each person identifies and experiences a crisis differently. Some may recognize the problem and use familiar coping strategies, while others may feel overwhelmed, lacking the skills to handle the situation, which can lead to poor decisions and potential harm. How do we as professionals respond to this? A crisis often involves situations that exceed the individual's or the family's ability to manage and require external intervention to prevent any further harm or dysfunction. The individual that's experiencing the acute mental health crisis may pose a risk to themselves or others. In such instances, the New York State mental hygiene law regarding involuntary transport may be applicable, which I will also come back to a little bit later. So when we were doing the tool, we broke it down from red to green, which will make a lot more sense on the next slide. So this is the tool in itself, and I know it looks incredibly overwhelming. We are very lucky in Erie County to have an abundance of resources. So I will go through each column and then we break them down in the slides to come. So that red is going to be severe risk, orange is high risk, yellow moderate risk, and then D is low risk. So the column right next to that is going to be defined as well as typical presentations that an individual may have if they're at this level of crisis. Next, you'll see mental health service action and response. How would we as the professionals respond? And when we are responding to that individual, what would our answers be of who could come, who could they call, where could they go, and then also additional actions to consider. So we will start with red, which is severe risk. This is defined as a person who needs immediate intervention and an appropriate crisis team assistance has been requested. There is a definite danger to life, whether that be themselves and or others. There's a severe behavioral disturbance and a total inability to care for oneself as a result of the mental health crisis. These may present as an overdose, possession of a weapon with intent to use it, a suicide attempt, or serious self-harm in progress, and may include other medical conditions that are a result of the mental health crisis. So in this situation, you're going to call 911 first and then call the appropriate crisis team. Crisis Services works with individuals who are 18 and older, and Spectrum Cares works with individuals who are 17 and under. So additional things to consider after calling 911, linking to the appropriate crisis team to ensure additional support is provided as needed, and also try to keep the caller on the line, whether you are the person taking the call or you're the person calling 911, until emergency services arrive or as long as possible. Next, we have orange. And this is someone that is in need of immediate crisis intervention due to significant risk of harm to others or themselves. So there's a very high risk of imminent harm to self or others. Just to put it in perspective, red was a definite intent to harm self or others. There is acute suicidal or homicidal ideations present with plans, mean, and intent. And again, that inability to care for oneself as a result of the mental health crisis. A typical presentation at the orange level may include violent behavior, extreme agitation, weapons that are readily available, impulsive or reckless behavior, acute suicidal ideations, or risk to harm others with the clear plan and means, and or history of self-harm or aggression, impaired impulse control, intoxicated or under the influence of other substances, and may require restraint. One of the things I like to throw in here is the case may not have all 6 of these things. They don't have to check every box for you to feel that they are at the orange level. So if this crisis is presented at the orange level, the mental health service action and response, triage a clinician to notify an ambulance. Another thing I like to specify, when we say clinician, we are talking about a licensed professional, whether that be a licensed mental health counselor or a licensed social worker. So if you see that word on there, that is what we are referring to. Make immediate referral to crisis services. If the person is 17 and under, that would be Spectrum Cares. And you can request an assessment from mobile outreach or law enforcement. A mobile outreach team will respond either by the phone or face-to-face and conduct a mental health assessment. Additional actions to consider: calling security or police if safety is compromised for the staff. It's also not listed here, but if it's compromised for the individual as well. Provide safe environment for patients, and also provide or arrange support for the client or the caregiver while awaiting that face-to-face assessment. Next, we have up yellow. Sorry, I keep having to move my little talking bubble. This is considered moderate risk. So this individual is in need of timely intervention due to the inability to cope with current stressors, but risk of self-harm or others is not pressing at the time of contact. So I'll break that down a little bit. So this may be possible danger to self or others. There may be a moderate behavioral disturbance, and this individual is under significant stress, especially in absence of capable supports. So we remember, going back a little bit, people may have capable supports and coping skills, but they are faced with a situation that exceeds that level. So this person, again, significant distress, and they don't have the supports that are needed to handle this exact situation. Typical presentation, there may be suicidal ideation, but there's no plan, or perhaps they don't have a history of suicidal ideation, and also rapidly increasing symptoms of psychosis or a severe mood disorder. There may be high-risk behavior associated with perceptual or thought disturbance, delirium, dementia, impaired impulse control. They're unable to care for themselves or dependents as a result of the mental health crisis, and also significant distress associated with a serious mental illness. Again, we have the nice word clinician. So again, a licensed professional. If a clinician's available, they can assess the situation, and they can devise a crisis or safety plan, whichever wording you use, as a part of treatment, and also monitor the client's behavior. If a licensed clinician is not available at your agency, on your staff, depending where you work, you can also call the crisis hotline. They can help assess the situation and determine a plan of response. Depending, you can also call the warm line for peer support. Additional actions to consider: if this individual already has a mental health professional, try to connect with that mental health professional instead of referring them to a completely new counselor, a new service, if they are currently linked. Also consider linking to a clinic with rapid response and open access, and obtaining additional information from any relevant sources. So if mom's worried about the client, if sister's worried about the client, and also, if appropriate, link to respite services. And then finally, we have our green, which is considered low risk. This individual is in need of intervention due to subjective distress or a low level of dysfunction. They're having a difficult time coping with current stressors, but they do not seem to require hospitalization. So this is low levels of distress. There is no danger present to themselves or others. There's no acute distress. There's no behavioral disturbances. A typical presentation would be someone that appears stable. They are at a low risk of harm. They're not agitated. They're not restless. They're not irritable, or I'm sorry, they are irritable, but without aggression. And they're cooperative with you. So they are willing to accept the help, willing to accept the resources. They're able to provide a coherent history. They may be experiencing symptoms of depression, low levels of depression, anxiety, adjustment, behavioral, or developmental disorder. This also could be early cognitive changes in older adults. So if you have somebody that's at this level of crisis, you can develop that crisis or safety plan with them. It can also include warm numbers as a tool for the client if they need support. And if symptoms worsen, of course, you can call 988 or crisis services, and also monitor lethality at each visit and determine if a response plan is being followed or if it needs revised. Because things change every day, right, for us and for clients. And if something is escalating or de-escalating, it's good to note. Additional actions to consider: facilitate appointments with an additional provider if needed. When I read this, LaTonya can correct me if I'm wrong. If someone is seeing a counselor and they would like to try medication, they could refer internally at their agency to maybe a psych NP or a psychiatrist to help them. And also follow up via the phone if deemed necessary. If you have an appointment with that person and you want to check in on them a little bit later, that is also something to consider. And then referring to the variety of services depending on the situation, respites, peer programs, and again, the warm lines for peer support. So all of that was a lot of talking and a lot of words. So how do you actually apply it to Erie County and where you work? So for understanding our local resources, again, we broke down into someone to call, someone to respond, somewhere to go. It's important to shift to community-based care. Individuals in a behavioral health crisis can get support, be assessed, and have access to immediate treatment for psychological needs. Crisis stabilization centers are effective at providing suicide prevention services, addressing behavioral health treatment, and diverting individuals from entering a higher level of care, addressing the distress experienced by the individuals in the crisis. So we did break down some of the main ones. We did have a very long list, and all of our services are wonderful in Erie County. But here are the main ones that we included. So someone to talk to. We did also break these down in 24/7 versus not 24/7. Especially depending who you're talking to, they really need to know if it's available at 3 a.m. So 24/7, you can call 988. Anyone can call 988. You can also call crisis services at 716-834-3131 for adults 18 and older, and Spectrum Cares at 716-882-4357 for youth that are under 18. We also have some non-24/7. So this is going to be Erie County Warm Line. I'll save you guys, I'll stop reading the numbers. And mental health advocates. So those are peer staffed and give great support to clients that are in need of it. Someone to respond for 24/7. Crisis services, again, 18 and older, and Spectrum Cares would be under 18, and of course, 911. So non-24/7 responses, we have quite a few jurisdictions that have a clinician or multiple clinicians embedded. Buffalo is one of them. They have multiple clinicians: Cheektowaga, Hamburg, NFTA, West Seneca. And unfortunately, when we put these slides together, there's a clinician at Town of Tonawanda. And unfortunately, there's not now, but just something to keep in mind. And then also somewhere to go 24/7, of course, CPEP. But we're trying to utilize where we can. Some people, of course, do need hospitalization and treatment. But if they don't, we want to find the right place for them. The Western New York VA Hospital is 24/7. I will say, though, they only take veterans. So that is also something to keep in mind. Best Response Intensive Crisis Center should, fingers crossed, be opening in the fall, and Refreshing Waters Respite as well. And then non-24/7 crisis sites, we have ECMC Help Center, Endeavor's East Haven, East Buffalo Rapid Access Center, and also the Renewal Center. For everything I just listed, as many of us know, the dates, the times, they change depending on staffing and grant funding and so many puzzle pieces. So something to think about when you are planning to refer a client to any of the things I just listed. There are different informational web-based platforms that you can access. You can call 211 or go on their website. Of course, there's also Erie Path, which you can access from the website or the app, and then Community Connector partner site through Value Network. So different ways that we can use this information. We did put some scenarios together for you guys. So I'm going to have LaTonya join me for this portion. If you want, do you want to read it or you want me to?
Yeah, I think I'm ready. You'll fill in where I may miss some things, but thanks, Deanna, for walking us through the tool itself and the resources, just really highlighting the resources that are available in the community for individuals to access, I think is important. And like Deanna already mentioned, things change, but it's still important to know that there are services that are available. So we hope that you've been paying attention. And so next we're going to review some questions to see how we apply this tool to real life. So our first scenario is Amy. She's a 32-year-old single mother of a four-year-old medically complex child. At her session with you today, she appears teary-eyed, stating she is incredibly overwhelmed. She lacks a support system and is feeling burnt out. She denies suicidal or homicidal ideations, but states that she can't keep going like this. So that's our scenario.
I did want to include, I'm going to ask you guys some questions and you can give me your guess in the chat, and then I will reveal what it is. I will go over this first portion though. What do you notice about Amy? She's teary-eyed, she's very overwhelmed, she lacks a support system, and she's feeling burnt out. And also she's denying suicidal and homicidal ideations, but states she can't keep going like this. So now I'm going to ask you to put it in the chat if you would humor me. What level would you classify Amy to be in? All right.
We have a couple C's in there already. D's.
It does. It actually, when they put it in, I can see like the little pop up.
All right. Perfect.
All right. Cool. Lots of C's and D's. I think I saw a B. Yes. Thank you for participating. I really appreciate it. So we did put Amy at low risk, and I'll explain why. She is having a hard time coping with her current life circumstances and could benefit from support. With that said, she is denying suicidal and homicidal ideations. There's no harm at this time, and we don't feel like she requires hospitalization. So I believe you guys will get copies of these slides, but if you go back, that's under, defined when you go to the green low risk. So something that could be good for Amy is connecting with Rome to see if they have respite beds available. With that, she would need childcare, which I know is yet another hurdle in the system, right? But ideally, they would be able to. She does need intervention to relieve her current stress, but she's not actively going to harm herself or others. Resources that might also be appropriate is facilitating an appointment with an outpatient or alternative provider, and also providing warm lines or link them to peer support agencies. I lost it for a little bit. I'll let LaTonya explain the next scenario.
Okay. So for this scenario, you can imagine you're at home sitting on your front porch, kind of enjoying a day like today. It might be a Friday morning, and you see a man who's about mid-30s, and he's running down the street naked, completely. He appears scared and is yelling that people are out to get him. He's running and he jumps onto the top of a car and crouches down as he screams nonsensical things. So he's pretty pretty kind of scary situation. So we'll do similar as we did.
Already getting
So
guessed.
what are
I
some
love
things
it.
that you noticed?
So
Go
the
ahead,
things we
Deanna.
notice, man, mid-30s, he's running down the street completely naked, right? Not a normal day. He appears scared, he's yelling that people are out to get him, saying nonsensical things. We would consider him to be severe risk, which is what I mostly saw in the chat. He requires immediate intervention. There's a severe behavioral disturbance going on there. While he's not making any direct threats, he is inadvertently a harm to himself or others just due to his lack of insight. So resources that would be appropriate in this scenario is, of course, calling 911, right? They have lights and sirens, they'll get there the fastest. You can also ask, because remember we talked about the non-24/7 response teams. There are clinicians in some jurisdictions. You may not know what jurisdiction you're in, and the client or the person that calling may not know what they're in, but if they ask the dispatcher knows, hey, we do have a clinician here, they're going to do their best to service the call to their best of their ability. So you could also throw that in there when you call 911. And link to crisis services in your county to ensure additional support as needed, and try to stay on the line as long as possible or until emergency services arrive. This one's a little long if you want it.
All right, so we're going to talk about Janice. So Janice and her daughter, they present at urgent care. Mom reports that Stephanie, her daughter, she's a college student living on the dorm, and she's always been an A student. She's always had close friends, and she, meaning Janice, talks to her daughter every day. So Janice, she hadn't heard from her daughter in a few days, and so of course she got concerned. And when she went to visit Stephanie's dorm room, she found that it was filthy and there was tin foil on the windows. Stephanie has not been going to class either, and she believes that the FBI is watching her. When spoken to, Stephanie takes long pauses before answering questions, and occasionally looks over her shoulder and giggles. Mom says to you, as the person that they're seeing, I made her come today because something is clearly wrong. So that's Janice and her daughter's scenario.
So, okay. So mom finds the dorm to be filthy with tinfoil on the windows. Stephanie tells her mom that she kicked out her friends because they're out to get her. She hasn't been going to class because she believes the FBI is watching her. Sorry, I can never tell where the thing ends. We do classify her to be high risk, and I'll explain why. She hasn't made any direct threats to harm herself or others. She is lacking insight to care for herself, and is making decisions that will harm her in the long run due to delusions, is definitely a big part of this. She's not going to class because she believes the FBI is watching her. And she's also not engaging with her friends who are probably normal supports for her because she thinks they're out to get her. So you can call crisis services and request a mobile outreach team to evaluate her. I am the one that wrote these scenarios, so we're just making an educated guess that perhaps this could be a first psychotic break. She is a college student. She's never acted this way before, and before she was very close to mom, getting good grades, had a lot of friends. So I wanted to throw in there ECMC and also Best Self have great first psychotic break programs. That either outreach here at crisis services can make the referral, or if she is transported to ECMC, they can make that referral as well. Other resources that are appropriate, call security or police if staff safety is compromised, provide a safe environment for the individual, Stephanie in this case, and arrange support while waiting face-to-face response from police or mobile outreach.
Okay, so now we'll talk about Sabrina. So Sabrina's story, her mom brought her in for a visit, and her mom reports she doesn't know what to do, and that she's telling you that. She won't go to school, she tells you. as you talk with Sabrina, you find out she's been dating Scott for 4 years. So she's been dating this gentleman since freshman year in high school. Sabrina shares that Scott went on a family vacation and ghosted her, and that he's been posting on social media but not answering her. Scott texted her last night, "Don't think it is going to work anymore. I'm breaking up with you," and hasn't said anything else. So Sabrina is unable to effectively cope. She states, "I've done everything for him. We were supposed to be in game. He was my future." Sabrina reports this is life altering for her, and she doesn't know how she can possibly continue. Sabrina refuses to go to class or to school, as she states she can't bear to see him.
I saw in the chat that Scott is a jerk, and I agree. I wrote him into existence. So what do we notice about what's going on? Scott texted her last night, breaking up with her, and then didn't say anything else to her. She's not able to cope. She says, "I've done everything for him. We were supposed to be endgame. He was my future." She reports that this is life altering for her, and she doesn't know how she can go on. And that part is definitely important. I haven't been looking at the answers. Where did we end up?
We had to split a lot of C's and a lot of D's.
Okay.
Oh, now a few B's.
So we did put her at moderate risk, and again, I'll explain. She has a possible danger to self. She has significant distress in absence of capable supports. We don't know Scott. He could have been her only support, and now, as someone's in the chat, he's being a jerk. So with that, she also has mom who has invalidated her stress in the scenario. Mom brings her in and she says, "Oh my God, it's not that big of a deal." Mom feels it's not a big deal. She's a teenager. She's experiencing her first breakup. But Sabrina is making those vague statements of not being able to continue, but she doesn't have specific means or a specific plan. She could benefit from talking to a mental health professional. Again, we're going to go back to the clinician. If there is a licensed professional on staff, which some offices have, depending again where you work, they can provide supportive counseling and safety planning. If there is not a clinician on staff, you can utilize someone to call, depending what time it is. If you feel like peer support would be best and it's within the time frame that they are available, you can call the warm line, or we have talked to many people in this scenario at 988. And if further intervention is required, the clinician can make a plan. Resources that are appropriate. If Sabrina already has a counselor that she sees, it would be good to check in with that counselor, say, "Hey, maybe we can get Sabrina in a little bit sooner." If she doesn't have a counselor, then let's link her with one. Provide after-hour peer support, so someone she can call if she's feeling the need to, and to consider link to a clinic with rapid response or open access. And then if you feel it's appropriate, you could also do respite services. This is a reminder that response times noted above are a guidance and should be left to the responding clinician to appropriately determine if their clinical assessment is complete. This is the disclaimer I gave you in the beginning. Again, this is not a clinical screener, a clinical decision tree. We are hoping that this can provide you general assistance as another thing in your toolbox when helping individuals in crisis. Ooh. Okay. If I stop this, they can see our faces when we go through questions.
Yeah, if you stop sharing it, our squares will be bigger.
Perfect.
Yes.
Sorry, I should have asked that beforehand.
All right. Well, thank you. So now people have questions. Feel free to put them in the chat and we have time to go through those.
So as people are thinking of their questions that they do have, just I'm not sure if Amy was going to cover this, but we will be making this available to organizations to support you in getting this broader than just this audience. So we do have this a version of it where it's actually just a video going through the slides and going through what we just did with you today. So we'll be making that available publicly as well. So those who are interested in having this information be able to use it in your organizations, we do want you to use it in your organizations. So it will be available to you.
I'm going to answer Sean's question. So I will explain, I do have a reason, but I do also want to say a lot of what we do is gray, right? They may not check all the boxes. You may feel one way and your coworker feels a different way. Between the woman that had an appointment and the medically complex child, she denied having suicidal and homicidal ideation. And she did say, I can't keep going like this, right? It's subjective. So when I write that, I read that she can't keep going how she's going. So if we resolve that situation, she's not experiencing any suicidal or homicidal ideation. Sabrina didn't specifically say that though. She didn't say, no, I'm absolutely not going to do anything. I'm not going to harm myself. She just said, I can't keep doing this. So that may not be what you're looking for. But again, it's going to be subjective. So it is a tool for you guys, but it may not have all the answers, or you may get a different answer or a different level to some extent. But still our biggest thing that we want is to utilize the services that aren't CPAP when we can. So if you felt
Deanna, that's a great point. And I just want to address one of the questions in the chat that came out kind of relative to that point, speaking about the need to tailor this tool or not in different populations. So I saw a question come up about the intellectual disabilities population. And I also saw somebody mention the use of this within a DV shelter. And both, I would say, are very great uses, because part of the tool here is to provide us as the providers and as the clinicians and as the ones who are providing the service to try to discern, okay, is this a trauma reaction that I really just need to maintain a safe space for somebody to sort of sit through for a moment, or am I seeing these sort of concrete suggestions of risk, which include that insight, right? So particularly when we think about the intellectual disability population, we're looking at, they can say things about being suicidal, but what does that mean for their level of functioning? What does that mean for their level of insight at that time? So it's a great question, and one could certainly argue various adaptations of this model. We've actually talked about that amongst a group, right? We're trying that within our clinical mental health fields right now, but ideally this would be a great tool for social services. This would also be a great tool for primary care physician's office, because we really cannot send people to CPAP. If somebody does not need a medication to immediately stabilize what they have going on, CPAP's not the answer. And so that's really what we're looking to address when we see around 7,000 people annually voluntarily present to CPAP. And so that tool is really meant to be a piece of that. And of course, the other part of it is setting the line so that if you use this system, this crisis tool, and you have concerns, things maybe weren't working, or there was an aspect of the crisis system that didn't respond to your need in the way that it was expected, we want to hear about that as a department. That's when we really encourage folks to reach out to us, to Amy or Kathleen, because it's part of our responsibility to ensure that those services do work, and that they work, and that they coordinate with each other. So anytime there are concerns, that's kind of admittedly the additional hope here is once we have that same understanding and we're all interpreting things in the same way, we can really help each other out when it comes to, okay, here's that appropriate level of crisis I have. Here's how I can explain my needs to a crisis services mobile outreach team and really work together to come to that resolution if necessary. But I just wanted to chime in. Sorry, I'll stop. Let Deanna.
I want to say something off what you said anyway. One, this is our first rollout, and we really rely on you guys for feedback, whether that be positive or negative. We can take either way, but that's how we get better. And the system changes. What the system was 20 years ago versus what it is now is different. The other thing that I think about when we're saying this person's this level, this person's this level, we also only have as much context as we have. So we may talk to these individuals or refer them to talk to someone on the phone, and more pieces come together for you to find out what would be best for them. So those are my two things. I don't know if LaTonya had anything else. I know we have like so many other questions in here.
Yeah. I'm just looking at some of the questions in the chat here. And this is good feedback as well in terms of wanting to have more context of information around the resources that are provided. I think some of the challenge is that because it'll be a document, it'll be static. And if something changes, it won't be reflected on that document. But definitely providing additional information for contact information for the different resources on there. We could put that information out for you, but just understand that these are resources that are known today, and the landscape is often changing. And so there will be additional resources that are not listed on that document that have come into the community. So it's ever changing, but we just wanted to highlight some of the resources that are available, so to just kind of bring it back to people's awareness that there are other options besides just going to the highest level of care for people and sending everyone to get the same resource. And sometimes that's just not the appropriate place for people to be able to actually get the care that they need for their specific situation at the time of their need. So that's a lot of what this is really working to highlight, is that there are different options for different people's situations. So question.
Sorry, my chat like keeps moving. I know, Sarah, you responded on the Chautauqua County one. I didn't know if I could just make a quick plug for that. Especially in rural communities, I'll be honest, I don't know Chautauqua County that well, but I would assume like we have rural areas in Erie County. It can be hard to get resources and to utilize them. Not even thinking about transportation or whatnot. But again, when we think about the system changing, who did respond 20 years ago or 50 years ago? It was law enforcement. So that's also why it's important to have that cross collaboration to ensure they get essential training. So when they do go face to face with a client, that they have the resources as well and the ability to have a trauma-informed lens.
I saw a good question in the chat about how to integrate this tool with some of the other resources locally. So the Crisis Stabilization Center, in addition to some of the other resources. As those resources come out, we really anticipate those resources being reflected within this tool as options for people to go to. And also, because it's really important that we remember that when we interact with folks, we are interacting with them in one moment in time. That moment in time can change in 30 seconds, and that moment in time can remain stable and take 6 hours to change. And that's really important because this tool can be used within the Crisis Behavioral Stabilization Center, best response it will be known as a triaging tool for folks that are working there, because just because somebody's there doesn't mean they may not re-enter either a state of trauma or a state of crisis, and they kind of need to sit back and reassess what's going on. Additionally, this is something that folks on hotlines can refer to. So I don't know that I have a specific answer yet about where it will sit within policy and like operational guidelines, but this really is a tool that we actively look to use to bring all of us together about what that resource is and when that resource may be best utilized. So that's more of a stay tuned sort of answer, but it's the best answer I got.
A few other questions maybe that came in. I'm going to try to read them before we answer them that way, because when people are watching the recording back or watching the recording, they won't always know what the question is. We have one that came in regards to when crisis services and the police are going back and forth about who is to take the lead on the situation. What do you do in that situation?
That's a great question. That should be a call into the department if it's happening in the moment, or your supervisor, right? Always, folks, start with internal policy of your agency, consult with your immediate supervisors first. But then, in addition to asking to support from your supervisor, if that question's coming from a director, you are welcome to call the department and seek one of us out. We can provide some answers.
Another question in relation to, and Katie, you might want to respond with a little more info. She works in a program providing legal services to the LGBTQ community. Are you seeing any kind of uptick with funding being cut to the LGBTQ suicide helpline?
Yeah, so I asked for clarity. Are we looking at uptick in what, I guess, was just my question. Because I think there's an answer. I don't want to give misinformation there. So I just was looking for a little more clarity on what specifically uptick we were looking at experiences. Calls for help, I don't know. I'd lean on Deanna for that, some 988 or 3131 context. And I don't have any updated suicide completion information at the moment.
Yeah, she just chatted back in. Calls for help, I think, is what she was referencing.
I will say, of course, there's a lot of funding news and a lot of 988 news, and there has been the news that the option on 988 was taken out for LGBTQ. But we are still taking those calls. We are still servicing those people. I can't confidently say, numbers wise, call wise, but if they're calling, we're still answering. But I definitely understand the concern.
Another question that came in: how should this tool be utilized within the work that is done at crisis stabilization centers and community-based teams like BHT?
That's the one I was answering. Sorry, Will, if you don't mind. That's the one I answered when I was like, oh, we envision it being utilized.
Great. I think a few more are just comments and just scrolling through. A comment came in: some of these symptom examples could mimic substance use disorders, like the example of the girl with the dirty windows with perceptual issues.
I will say that's, of course, a challenge when you're working with clients, especially clients you don't know about, don't have a history on. So it is warranted to have more questions. Again, those scenarios are just a few sentences or a few paragraphs, but if you are referring them to someone, or you are the person working with them, or they do end up at the hospital, the psychiatrist will likely order a drug screen. But if they are seeing you because of a substance-related issue, it warrants the question. So I wish I could give like a concrete, absolutely, this is what I would do. But again, hoping to provide a little guidance, and whatever feedback you guys have is very welcomed.
That is a challenge. I will say it's the common theme, no matter what the population seems to be, whether it's children, and again, I'm saying this is like wide breadth brush strokes here, it's like, what does that level of insight look like for that individual at that time, right? Whether they're using substances or have an intellectual or developmental impairment, or there's significant anosognosia because of the mental health disorder. That level of insight that somebody is able to talk about, what a child is able to articulate to suicide means something, right? And that is why it is incumbent upon us as the professional to really siphon through, what do we know, what don't we know, and when do we need to really call in the experts to look at this further, because sometimes those additional factors can make things difficult when we're assessing for risk and when we're trying to determine what that next step is. So we really encourage folks to look at this tool as that foundational model of, this is what we can implement. But remember, you have local experts who are able to assist you within that risk assessment tool. And that's really what we want people to remember when it comes to trying to discern between the differences within populations.
Just scrolling back a little bit, a suggestion from Colette came in to have the resource list with full contact info. Suggestion in regards to that resource list.
It can be kind of hard, right, to list everybody's number of every resource. I think that's why it's so important to keep in mind the web-based platforms. You do have a few to choose from, whether that be Erie Path, Community Connector, or 211. And you can also call 211. So if you're not finding it, you're struggling, you know, with the web-based or the app, you can call them as well, and they should be able to help you. Because again, things change, time change, and whatnot, and we don't want the wrong info to be there because the day it's printed, it's out of date, right? Is the saying. So definitely just trying to utilize those resources of finding more resources.
Oh, that's annoying. My apologies. I just put find help in the chat. It is still very much an active website, but it shows a coronavirus thing. I'll have to flag that for the state because that's probably not a great look. That is not a COVID related resource I put in the chat. My apologies to the group.
All right. Any other questions we didn't hit on? I tried to scroll back and make sure we answered most of them, unless any of you see any we didn't touch on. All right. Well, thank you, Deanna, LaTonya, and Sarah for your time and for the great presentation. Amy has put a few links in the chat. The first link is the link to our brief evaluation, so please just take a moment to complete that. She also put the registration link for our August training, which will be on grief and loss, into the chat as well. Oh, maybe not. Maybe was that the link for our training collaborative, is what's in there. And then our upcoming, yeah. The recording and slides of today's presentation will be posted to our website, so please check back over the next few days to see those. If you're interested in bringing a presenter, please let Amy know, or you can share that on your evaluation. Or if you or anyone from your team has a topic of something they're interested in, let us know as well. And again, thank you to the team for such a wonderful presentation. And thank you all for participating.